Hey guys, it's me again. I hope that you are all doing well. Today's lecture comes from you again from the hammock, and Artie is over in the corner playing with her bone right now, so she's semi-present with our lecture today. Couple housekeeping things, and just to keep you guys updated. Last night I was able to get a bunch of stuff done and posted. I'm trying to kind of get things done ASAP so that you can kind of work at your own pace. I even have the final half written. I'm going to include a question just to get some feedback in this week's written prompt about if you guys want the final open earlier or not, or just keep it the same dates as in the syllabus. Because I don't know if you guys are just kind of puttering along, or if you want to hurry and get this class done, or where you're at with getting your schoolwork done. I will try to finish up recording the lectures now that the PowerPoints are done and posted. So if you guys want those, I'll try to get those done this week. And then I will hit it hard on grading. I will make it so you have to have everything done before you can take the final, though. But yeah, if you guys want to move ahead, totally great. Another update, I know, not to talk about me, but I know you guys are probably kind of wondering what's going on the hospital side of things with this pandemic. I've been a little bit, not out of the loop, but I'm kind of more second line defense with all the corona patients because I work primarily in the NICU. So I'm just planning on the next few weeks having it hit me personally hard with my employment. But most of the RTs that work in our medical ICU are the ones that have been taking care of the corona patients. Right now, we're totally fine, us-wise. My department has been gathering and stocking up equipment like squirrels getting ready for winter. We can't even move in our department right now because we have so much rental equipment. And we're doing okay with masks. We just have to use them sparingly. We can't be wasteful with them. Because I know that's a lot of what I'm seeing on the news. But yeah, that's this week's update on pandemic and how we're handling it at the U. We have a few patients for sure, and then we're also the ones that are getting transfers in from smaller hospitals that can't really handle it well, handle those sick patients. I hope you're all staying well and staying clean, and you guys are on my mind. I just want the best for you. Okay, here we go. Today's lecture is on waveform analysis. A lot of these pictures will be very similar to the Lindsay Jones. Okay. Critical opening pressure, get it? Because that is also synonymous with PEEP. I'm going to apologize. A lot of the pictures in this PowerPoint are hand-drawn by yours truly, and as I have told you guys aware, and as you've been well informed, I am not an art major. So it might not be exact, but I tried my best to make them as clear as possible for you. This lecture will be split into 3 different sections. It'll be the pressure volume loops, waveforms, and then we're also going to discuss alarms in this lecture. Because I remember alarms being kind of fuzzy when I was a student. So we'll break those down. So back to junior high math. I'm sorry for the PTSD. Back to algebra 2. Oh, so help me. I remember being in 7th grade math class, and this cute guy was sitting right behind me, and I was eating my juicy fruit gum. And if you guys haven't had juicy fruit gum, that crap like dissolves. And it was very embarrassing because I just had like foam coming out of my mouth. It was great. All right, so pressure volume loops, they are shown on an X and Y axis. they will correlate to the pressures on the bottom and volume, so along the x-axis, and volume is up on the vertical on the y-axis. This will mostly pertain in the positive plane because we are giving positive pressure, since mechanical ventilation is positive pressure ventilation, with negative deflections into the negative plane depending on patient effort. So just our normal basic machine delivered loop. One thing I will say is when you do look at these on a patient, because it is a patient and a sick patient on a ventilator, things are not as pretty as in pictures and on textbooks. There will be a little bit of variations. The patient and the relationship between the patient and the vent is very dynamic, but we show pictures that are very static. So that's my lecture on that for 2 seconds. So along the bottom we have pressure, along the Y we have volume, as we said. In this lecture, yellow is inhalation, red is exhalation. Note that right here it starts at 0 at the base. So we go to inhalation. As you can see, we can come down and see what pressure is needed in order to deliver what this volume is. And that's how that relationship works. So we start at our base, or our PEEP, or wherever. We come up to inhalation. We reach either our set PEEP or our set volume. This is the pressure that we need in order to obtain the volume we need. And then we exhale. It should look like a nice little football shape in about the middle of the XY axis. So patient triggered. This is what some will call a little fishtail, and it can indicate patient effort or patient triggered breath. So what's happening is the patient's dropping their diaphragm right here, which then triggers the vent either by flow or pressure. You can set, we'll just kind of talk about sensitivity for a minute. Sensitivity, the higher the number on it, so like 2, 3, 4, the higher the number, the more effort the patient has to put, so the more negative the patient has to pull in order to initiate that breath. This can be either delivered in a flow, so we're altering flow, or pressure. So I like to think of it as we just have air continuously flowing in the circuit. Either that flow changes a certain amount, or that patient drops their diaphragm a certain centimeters of water pressure in order to trigger or initiate a breath. So that's what the negative force is, and that's how it's related. So if this is really, really big, and the patient is looking like they're getting tired, they're pulling a lot, that's when we might adjust our sensitivity. Inversely, for example, I had a little patient. She has been in the ICU a really long time. She's super sick. She has a couple things wrong with her heart, but then also she has a fistula of some type going on with her. So she does these little baby breaths where she's just kind of panting almost, and it's auto triggering the vent. So it would just, the vent would freak out, it would alarm, she would take tiny tidal volumes of like 30 and then all of a sudden like an 800. And so I ended up moving her to a pressure sensitivity and increasing it to 4, and that way she actually had to work to initiate the breath, which she was strong enough that it didn't tire her out, but it also didn't auto cycle the vent. So those patients that just keep triggering, so triggering is initiating a breath, are the ones that you might need to check sensitivity. So we trigger the breath and we go inhale and exhale. Okay, that's a patient triggered breath. So opening pressure, this is your PEEP. If you have a flat bottom, we don't just think with pressure volume loops, we want the Queen song Fat Bottom Girls. We don't want flat loops, if that helps you guys think it through. So if you have a flat bottom, what's happening is we are not reaching the opening pressure that our lungs need. Our critical opening pressure that our lungs need is not met with the PEEP. So that means we have inadequate PEEP, and we need to increase the PEEP to reach it. And if the patient is in a control mode, we can actually freeze on some of these newer vents and measure it out. But then what will happen is you'll increase your PEEP, and then your loop will reset to here, but you'll be able to oxygenate better, and your lungs will be open at an appropriate pressure. So you'll increase your PEEP. We'll say like this one, we'd go 1, 2, 3, increase our PEEP by 4. Let's say we were at 6, so we would go to a PEEP of 10, for example, and then we would meet that opening pressure that we need in order to properly oxygenate and recruit our patient. So we want fat bottom girls, not flat bottom girls, according to Mr. Mercury. Think about it that way. There we go. On the other end of the world, say our PEEP is fine, but we are giving too much volume into the lung or too much pressure. This is sometimes called a bird beak loop. And what happens is we're going on inhalation, and where this breath wanted to stop right here, because if you followed along, you would track it here, we're just continuing to give volume or pressure. So that's why it's kind of sad, and it looks like a bird. So we come on up, and your lungs are like, oh, perfect, I'm done. Oh, wait, okay, you're giving me more? All right, I'm just going to kind of peter out here and just take more than I can really take. And then we're going to exhale. You would fix this by either decreasing your tidal volume or PIP or adjusting your flow or I time. So you could do this by shortening your I time, so it would be a little bit faster, because sometimes that I time you're like, oh, sweet, we met it here. Okay, I'm still going. It's too long. Same with flow. Think of it as your bird ate too much. You got a little chubby bird that needs to back off and doesn't want to eat as much. So then to bring it to the other side, we have not enough. This would be a leak, presence of a leak. So if we have inhalation, but our exhalation does not meet the base, come back to base, we have a leak somewhere. Whenever I have a leak, most of the time you can hear it, or your return volumes will be down. But if I have a leak, I like to think, always assess from your patient out, but most of the time it's a mechanical issue. This could be, there's so many little connectors and adapters, something where maybe the heating wires were plugged in, got a little bit loose, or up at the suction is a very, very common place to have a small leak up at the suction by the patient connected to the ET tube. Just check your patient. They might have a cuff leak, and then just work your way down and see if you can hear or feel or notice where a leak might be occurring on this patient. And that's why, because it's like, I don't know what my return volumes are, because they're escaping somewhere and I don't know where it's escaping to. Ventilators are smart, but they still need a respiratory therapist guidance. Compliance. This is probably the worst picture I've drawn. I'm sorry. So one thing you can see, oh hi Artie, with compliance is how flat the pressure volume loop is. So I like to think the worse my compliance, the more flat my pressure volume loop is. And so therefore the worse my compliance is, where a normal compliance or wonderful compliance, because we need just a small amount of pressure to get a large volume. So Whereas this, we need lots of pressure in order to get any type of volume. This is pretty common. So again, as you guys are aware, I mostly work in the CVICU, the cardiovascular ICU. We will get patients with very severe ARDS that we put on ECMO, and their compliance is nothing. So this will just kind of circle here, basically flat. But then on the other side, if I have a post-operative patient, I just need to, that they are previously healthy, their biggest complication was sedation, then a lot of times it'll be pretty tall because their lungs are healthy and it takes that volume in really well. So just a small amount of pressure to get that volume in, and they are ventilating lovely. So that's how compliance, the changing compliance will work. I'm sorry, this picture is kind of bad. But I think flat is bad, tall, we want them all. I don't know. I don't have a good one for that one. Okay. Moving on to waveforms. This is ones that you probably have seen the most on ventilators. Different companies have them set up differently. So we can see how the tidal volume is delivered, and what's going on with the patient. So, number one thing I like to notice is, next time you guys get your hands on a vent, is how flow and volume waveforms adjust how steep we deliver the breath. I like to think that volume ones look like waves, like in the ocean. So we have our delivered tidal volume. So this is our flow up to inhale. And so this is our volume. This is time. So with our flow, we go up to inhalation, peak inhalation, and then exhale. This is an example of a machine-delivered breath. A lot of times PEEP is, you can see by, that will kind of increase where your volume is. So if we were to increase the PEEP, these waveforms would be just a little bit taller, a little bit more up off the base. Down here, you can see the patient trigger breath. So for this patient, I have them at a PEEP up here. The negative deflection is the patient triggered breath. So patient diaphragm drops, patient breathes in, inhalation, down to our base, PEEP for our exhalation. Remember, yellow is inhalation, red is exhalation. I know you have to look for the negative deflection on some of them. I know on the Draeger, if any of you guys work with the Draeger vent, you definitely will when you do your neopeds rotation. They have different colors for machine delivered and patient triggered ventilatory breaths, which makes it really nice to see. Pressure, I like to think, again, we're going back to junior high. This one's geography or geology. I don't know, one of the classes that I hated. The pressure waveforms kind of look like little plateaus. And this is also, you can see how eye time affects. So we go up, we kind of meet our pressure, but we're going to continue that pressure with that eye time. So say we have a very restricted patient and I give a longer eye time, we'll go up in our eye time, but we might end up holding it there for a little bit longer to allow for recruitment, and then we exhale. Whereas if we had a shorter eye time, say for an asthmatic exacerbation, it would go up and then come down and allow for a lot longer expiratory time, sorry. So we can come up and short, and then longer time to exhale, or a little bit longer time to inhale, and we come down to exhalation. Just like with volume, we have our machine delivered that just come to our base, where we also have patient trigger. So these are very similar. Biggest thing is pressure looks like plateau, volume looks like waves. Flow's a little more tricky. It's one I don't frequently use and is not commonly used on many of the ventilators I've worked with. It's kind of a more dramatic image of inhalation versus exhalation. So think of it as it's both above and below this x-axis. So we come and inhale and then exhale. Inhale, exhale. It's part of the reason it's not commonly used is because with flow, there you can get so much artifact with flow, whereas pressure and volume you have pretty exact, where yes, we set exact flows in volume, but you can have different variations at any time. So here's some more visuals if you guys needed to kind of go over how you can see the difference in flow and eye time. So this would be like a 30 liters per minute flow. It would take longer. We have a lower flow and then a little bit shorter expiratory time. Again, that would be used for, say, a restrictive lung patient, say somebody who had pulmonary fibrosis. Meanwhile, we have someone with an obstructive issue, and it'd be a quick breath in with a longer expiratory time. That is for volume, and here is pressure. So we would have a longer inspiratory time. This is a 1.6 inspiratory time coming up to our PIP, and then we have a little bit shorter. Meanwhile, we'd have a shorter, a 1 second up into our PIP, inhalation and exhalation. This one's not perfect. Again, I'm sorry you don't have an art major for a teacher. Okay, a few things that might look a little bit off when you're delivering a breath is some anomalies or some artifact that might be occurring. If you see waves on exhalation or on inhalation, so typically waves on inhalation are secretions, waves on exhalation are condensation. Either way, these are simple fixes you can make by either checking your condensation, making sure it goes into the little drainage cups on the circuits, or suctioning your patient and figuring out maybe something's up with your heater, troubleshoot your heater. That's probably the most common one you will see. And it's kind of a nice thing to know because as respiratory therapists, again, this is our specialty. And I've had situations where I've been suctioning my patient and the doctor has asked, why do you look at your vent after you suction? And so I got to be like, well, you can see the secretions. They're like, I did not know that. Well, that's because this is my toy. Another one is inadequate flow. So if the patient is just kind of has putting in a lot of effort, so peaks up to inhalation. Think of it as my patient is starving, so that patient is just taking as deep a breath as they can. They're trying to pull that breath in, but the flow is too slow or their eye time is too long. So you would either increase the flow or decrease the eye time because it's taking too long to get that breath in and they're just starving. They are air hungry for that breath. Okay, a lot of you asked about auto PEEP, so we're going to spend a little bit of time on auto PEEP. I like to think of auto PEEP as the patient's additional PEEP. This is additional pressure above my set PEEP. So this is pretty common with symptoms of air trapping, so obstructive pathologies. So the one example I saw when I was a pretty new RT, I had a asthma exacerbation patient, and they just were not ventilating, and but their pressures were climbing, and we were literally had to just unhook the patient from the vent to allow her to exhale because she had so much air trapping going on. So let's say I have my PEEP set at 5. The maneuver you will do is an expiratory hold, because what that will do is it will hold it at expiration and it will measure. So then it will tell the difference. So let's say I had my PEEP set at 5. I performed an expiratory hold, and then I got a measurement that we are at 8 or 7 or 8. So this patient has additional PEEP on top of it. How you would fix this is by either decreasing the respiratory rate, which would allow a longer IDE ratio, allow for longer expiratory time, shorten the I time or increase the flow, and also you would want to address the problem going on, bring it back to your assessment and to pathology. You want to give a bronchodilator. You want to start getting that inflammation and those bronchospasms under control. Those are how I would go about fixing it. That's auto PEEP. And as you can see on these waveforms, this little dotted line is my set PEEP. See how it comes down to base above it with my super technical pictures? That's another way you can tell if we are having an auto PEEP issue or an air trapping issue on the waveforms. If you guys need me to explain this again in another lecture, please let me know, because I know you guys had a lot of questions on this. So just think of it as patient PEEP on top of my set PEEP. Okay, alarms. I split this into what Lindsay Jones has and possible real life, because that's how we roll. Lindsay Jones values, these are for your boards. So you would set up your patient. This is your peak pressure, your measured peak pressure. You'd want to set that 10 to 15 above the baseline. So like if your patient had a peak pressure of 17, you'd want to put it like 27 or 30 around there. Low, oh gosh, I'm sorry about that. Let's fix that. A low pressure. Typically, a lot of ventilators don't have a low pressure. They just will have a disconnect alarm. If you're having low pressure, you're just going to have disconnect. Then you put this 10 below baseline. So again, our 17, we would put it like 7. A low volume, 100 below your set tidal volume. So let's say you had a 400 tidal volume, you would set it at 300. So respiratory, according to Allie, your preceptors might have different things that help you guys out. And again, there's more than one way, especially with alarms, there's more than one way to skin a cat. This is how I like to set up my ventilator alarms. So I like to set my peak pressure at 40. That way, if I am hitting 40, I know something is wrong. It will allow for pulmonary protection. I'll be alerted. I'll know something is wrong with a pressure of 40. But let's just say my patient coughs and their peak pressure goes up once or twice, but then it goes back down to a normal healthy range. Good for them. They got a good cough in. Sounds great. Same with a respiratory rate of 40. This will indicate if my patient has increased work of breathing, but let's say they're turning the patient and they're just a little bit stressed, but then they go back to their rate of 20, 22. Then I'm like, all right, that's okay if you breathe in the 30s while you're getting your butt wounds dressed. I would breathe fast too. That sucks. Moving on to minute volume. I like to use it as kind of more for kind of letting me know. I definitely want a low minute volume in case my patient decides to poop out on me and just not want to breathe, or if their tidal volumes are decreasing and maybe their compliance is getting crappy. But a high minute volume is just kind of, is my patient panicking? Is my patient have a high respiratory rate? I'd rather my respiratory rate alarm let me know than my high minute volume, because sometimes if you're weaning a patient and they take a big sigh, it will send your minute volume up. And I'm like, well, they just took a big sigh. That's okay. Which brings us to tidal volume. I like 1,000 unless I have a patient with crazy compliant lungs that maybe they're intubated for upper airway swelling or a trauma or neuro reasons. I'll put it higher because say I'm in a minimal vent settings and they take a sigh, I'm like, good for you, you took a big sigh. But then my tidal volume, say they're kind of just took a little guppy breath, I want to make sure I'm aware if we have a disconnect or we're low or decreasing, but I don't. Oh, don't lick my microphone, sweets. Sorry. Somebody just needs their paw held right now. Then I can know if my volumes are being inadequate for any reason. So, also what I would say is adjust your alarms to where you're comfortable. I'm pretty close to my vents. I don't travel real far from them. So that's why I like them just a little more spread out. But typically, if you stay in these ranges, most of my coworkers are happy with these, around these values, unless something is very, very off. Like I have an ARDS patient, so my peak pressure I put it at 60 because everybody's aware our lungs suck. Or I have a patient ready to wean and he's 6'5", and so I put this up at 2,000 because he takes giant volumes because he's crazy tall. All right. That's the end of this lecture. Make sure to respond to the writing prompts. The lecture. This is already with my nieces. She loves them. Respond to the writing prompt. Take the quiz. I'll work on getting the rest of the lectures posted. I'll just finish off this with, apparently I was not thinking the other day and now I have fringe bangs. So don't listen to the life advice of cut your own fringe bangs. So the secret word of the week is fringe bangs. All right. Stay safe, guys. Wash your hands. I'm here for you if you need me. Keep me in the loop. You're all awesome. Bye.